Welcome to the 200th episode of the Beverly Hills Plastic Surgery Podcast. That's right. I'm here with my 200th episode partner in crime, Dr. Millicent Rovelo. How are you doing?
I'm doing great. I'm doing really, really well. And I am so excited that you have put up with me for 200 episodes. I'm feeling pretty happy about that.
Au contraire, it is you who have put up with me. You have declared rant-free zones on multiple occasions, and now it is time for us to take questions from our listeners. That's what we're doing for our 200th episode.
So we've been accumulating these questions. Some of them have come through the podcast. Some of them have come directly from our own patients, but they're kind of like, some of them are like common questions that I get a lot, and some of them are kind of the ones that make you go, huh. So I'm going to ask you some of the ones I've received and vice versa. You're going to ask me.
Sure.
But first, shall we make a toast?
Absolutely. We had to do the only pain I want in my life is champagne.
So we were going to open this on the podcast, but it's Friday afternoon and it's been a really long week. So I was like, can we please have some before the podcast? So if I'm like a little more charming than usual.
So we missed the pop though. I'll do it for you. There you go.
All right. So cheers, Doctor, to
200 episodes. Cheers.
Clink.
Oh, wait. We should do that right into the microphone. Take that one. Yeah, go ahead. You do it.
Okay. Ready?
Go. Nice. Good job.
Thanks.
Yeah, we need that. So I think just before we get into the questions, some of the highlights of why this podcast has been not only enjoyable to do, great as a resource for our patients, but I think some of the things that have been surprising to me that I didn't anticipate when we got into this was how much the podcast would help me compartmentalize and focus information, not only for myself, but for teaching, for patients, even for my own understanding of just exactly what it is we do here. You know, it really does help to kind of bring a arrow-focused kind of way of thinking about plastic surgery. It's really been powerful.
No, 1,000% agree. There's so much that we know from what we've learned in our training, from what we've read, from just, the hands-on practice that we do. But when you have to verbalize and make that training and knowledge concise in 20-minute episodes, you really have to kind of organize your thoughts and put it down in a way that makes sense. And in such a way, it actually you kind of learn something in the process. Like, oh yeah, that's why I do that. I mean, I knew that, but now I know why I do that.
Right. And that's the thing. Verbalization of your thinking is really a key component to being able to understand how to make progress in your own practice, but also about how to teach others and how to teach yourself. I mean, somebody said to me, do you think AI is ever going to be able to do surgery? Like, do you ever think that can happen? Can AI do plastic surgery?
That's like the first question I had.
Oh, is it?
It's up there because I've been getting that a lot.
Well, let's answer that question then. So, question from our listeners: can AI do plastic surgery? What do you think?
Not to disparage any other surgical or medical professions, but I do think that there are some surgical, and disparage is the wrong word, there are some surgical professions where AI might be able to do the job because we already have robotic surgeries doing, gallbladders, colons, prostates, gynecology surgeries. And true, there is a human on the other end of the robot operating it, but theoretically, that robot that's already been trained and programmed with the arms and the utensils and the instruments could develop a way of being able to think on its own how to analyze the situation and do the surgery. Plastic surgery could potentially become that as well, but there's so much, loosey-goosey, fluffy artistry. You got to feel the tissues and know how they're going to respond to you that maybe with really technical AI could be done, but right now we are so far off from that. Because even if you look at a photo of people and say their breasts look more or less the same. Once you examine them in person, this one's skin is so much looser. This one's breast tissue is really tight. Like they want to have this look. Oh, their body's shaped this way. I don't know that we're there with AI. There's a lot of artistry to what we do, which I guess could be trained. I mean, AI is doing art. We know that. But I don't know. What do you think?
I think that if I can verbalize it, then I can teach the computer.
I disagree.
I do. I think that I can explain why things look good to me. I explain it all the time in surgery. I explain it almost to myself when I'm teaching the fellows, when I'm teaching the residents, when I'm at a conference, when I'm in, in going through a preoperative evaluation of a patient. I'm sitting there going, boy, this patient's nose looks this way because of these things. And in order to affect a major change to make the nose look more beautiful, these are the 17 things that need to happen. And sometimes it's 99 things that need to happen. It's, the bottom line is I can verbalize it.
But how many times do you get in there and the plan that you made changes because you realize that something internally is different than what you expected? Or on the table, that move you made just doesn't look right all of a sudden?
Every time. Every time those things come up, and you have to be flexible. But I think that it's teachable. And so if I can teach it, I think you can program it.
To make a J. Calvert nose.
Or
there are other surgeons that have different aesthetic views.
Of course.
So
and I think it can be
in the same way an AI could make a photo or a painting in the style of Rembrandt or Van Gogh or what have you, Matisse. They would make a nose in the style of J. Calvert, which you would then own the rights to.
Which would be awesome because we don't get paid for
because then
inventing things
you could
ever.
just sleep and collect the royalties.
That'd be great. I mean, think of all the surgical techniques that get invented that nobody gets paid on.
Sure.
Unfortunately, in our culture, we've decided that you can't make money from surgical techniques because it needs to be disseminated for the greater good of human beings. Now, if you program something that says this is how you make a J. Calvert nose, you get money every single time programming gets used.
We have canal stitches, Benelli mastopexies, Wise patterns, 1,000%. All of these giants of surgery that have...
And nobody gets paid.
Yeah, they get no credit.
Right.
Okay, so that's question number 1.
Okay.
We got to move along. All right, so that was a question that I received. What have you got for me?
There was a question that came in that always makes me go like, that's not how that happens. It just makes me go. Like,
listeners, sometimes we have to really struggle to keep a straight face.
It's hard.
Because all of your questions are super valid, but sometimes they make
because
us
you
giggle.
can't. Well, here's the thing: is like you try to imagine, like, how does that happen?
Mm-hmm.
They must cut the nipples off when you do a breast lift. See, that was your response.
That is a very serious question.
It is a very serious question, but that's the question: do you cut the nipples off to do a breast lift?
Do a breast lift, and it makes sense, right? Because you take that nipple, which is staring at the floor,
right?
And now all of a sudden
down.
it's looking like front and center on camera,
right? So you must have like pepperonied that thing, put it on the back table, and slapped it back on after you've lifted everything else on.
Not true.
No.
So the nipple is usually attached. We need it to stay attached because the blood supply to the nipple is coming from deep on the chest wall, from under the ribs. So we need that nipple to stay attached to the chest wall. So we cut all the way around the nipple, leaving a healthy section of tissue underneath it that has the blood supply that's called the pedicle. And with it being completely cut around, we now have complete mobility of it. We can move it up, down, side to side, and put it wherever we want it, and then close the rest of the skin around it. Now, in very, not rare, but every once in a while, in very large breasts, we do actually have to cut the nipple off because the blood supply is not going to survive because the distance is too long for it to travel. So in that case, we actually do cut the nipple off and sew it back into position. That's called a free nipple graft. But on average, no, we're not cutting your nipple off.
Right, but it seems like that would be the way to do it.
But it seems like, so which segues me into the question for you. I heard when you do a facelift, the ears are cut off and then put back on. Because the incision goes all the way around the ears. So clearly you've detached it from the face.
No, you do not cut the ears off. The ears stay attached. It would make it easier if you cut the ears off.
They'd be out of the way. You could do
Right,
so
it'd be
much.
great.
Yeah.
But we do not cut the ears off. We simply cut around the ear in a very strategic pattern.
Very superficial.
Some of us cut more strategically than others. That's all I'll say.
Check out the Facelift
I'm just
podcast.
saying.
Nope.
Okay.
Move on.
Rant-free zone. Okay, this is going to be a rant-free episode,
Yes.
I see.
Yes.
Are you sure?
Yes.
Fine. Okay.
There's 199 other episodes that they
Plenty of
can
rants.
listen to rants.
Because there need to be rants. There need to be. Because I don't think that people
There we
understand
go.
how plastic surgery works without the rants. Because when you hear me rant, it all of a sudden makes you go, I should look into that. That guy seems pretty peeved over the incisions of the face. So anyway, you don't cut the ears off. They stay
You do not.
attached. You cut around the ears. There's very strategic anatomy, sort of anatomical aspects to that incision that hide it very well. And
Yes.
interestingly, I will tell you that yesterday I saw a patient of mine from 13 years ago who had a mid-facelift, brow, eyes, four-lid bleph, and looked great from here up. For some reason, she must have had a psychogenic fugue or something, and she went elsewhere for her lower face and neck approximately 3 years ago.
Mm.
This facelift included in front of the ear, not in the tragus, but in the skin fold between the ear and the face incision that went behind the ear and then came down on the neck. But it's almost like they missed the hairline. So it was in front of the hairline by like a centimeter.
Yikes.
It was so bad that I bit my tongue and just said, I'm just not going to say anything. It's okay. It's going to be okay, everyone. It's
And
gonna be
listeners,
okay.
we're going to refer you to the natural lift, doctor.
Natural lift, please.
Next question.
Okay. I'm going to stop. You really don't want me to get into
I
a rant.
don't. Our listeners have questions that need to be answered.
Okay. The next one is, what's with the mesh?
Oh, the Maya in Espanol.
Ah,
The Maya.
sí.
Yeah. So mesh can be many different things. In our world, it can be mostly absorbable, although there are some forms of permanent mesh typically used in the abdomen, not so much for what we do in plastic surgery. But we use a lot of mesh in the breasts. Mesh can be cadaver skin, so literally what it sounds like. It's harvested from a cadaver, it's washed, it's denatured, all the live elements are removed, and then we put it back in the breast, typically for breast reconstruction, for capsular contracture, or it can be a completely synthetic mesh that we use for soft tissue support in the breast. I use it in the breast a lot. I love it. I think it serves a great function. And when you need it, you kind of need it.
Yeah, I mean, I love the mesh in terms of defining the inframammary fold,
great.
in doing symastia repairs. Symastia is when you have where both breast implant pockets meet. It's uniboob.
It's a uniboob.
Yeah, so it's not cute. And that's a hard repair, by the way.
So hard.
I don't think we've done symastia
We have not.
as a. So make a note, Sean Gosser, our producer of 4 bazillion episodes of the Beverly Hills actually 200 episodes of the Beverly Hills Plastic Surgery Podcast. Make a note, symastia. We're doing that
Symastia.
one. That's a
Yeah.
very important episode.
Mesh is great. We can use it in a variety of places, and it's very helpful, and I love it.
Great. I
Oh,
love
yeah.
it too. So that's what's with the mesh.
That's with the mesh. All right, doctor. Is plastic surgery addictive?
It depends on who you are, I think. I think that most people would say that it is addictive. I think that you get into it, and I think that you find yourself. I think if it's successful, it becomes a little bit addictive.
I think it is.
A little bit.
I think there's a certain, if it's successful, there's a certain euphoria that you get from seeing these changes, and then you know that it's possible. So you want to see what else you can do. And I can't tell you how many patients I've had that on their initial consult with me were like, look, I'm not a plastic surgery person. I just need this one thing fixed. Maybe it's something therapeutic, like a breast reduction or a rectus diastasis repair. Like it's something they feel they need sort of for their health.
Right.
And then they see the results. And 4 surgeries later, we've done like the brachioplasty and the mastopexy and the facelift, but they're not plastic surgery patients. So I think once they see what's possible, then they really get into it. And I
Right.
remember in particular, a personal anecdote. I was having plastic surgery. And while I'm there, a nurse who works at our center, who's very familiar with me and she knows me, she was like, I'm so jealous. It's been a couple years since I've had any plastic surgery. And I really want to do something.
There you go. But I don't know if it's addictive isn't the right word, because addiction means that it's like without control, that it's, it has a maladjusted connotation, right? So I don't think it's addictive that way.
But there is a dopamine hit, like in the same way that social media feeds a dopamine surge. Obviously, you're not doing plastic surgery every day on yourself, but I think that there is some euphoria and a dopamine hit that you get from, getting these results that are really transformative. So
They are.
There is a gate. I think there's some gate. It's a gateway.
Yeah, I mean, I get it. I think there are. So I'm not going to rant, but I was on a episode of the Dr. Phil show where the subject was, is this too much plastic surgery, basically? And they had a patient who had 49 plastic surgery operations, and his surgeon was sitting next to me, and he was on the stage talking about what he's going to do for his 50th plastic surgery operation. And he'd had bicep implants, pec implants, facelift, chin recontouring, rhinoplasty, liposuction, you name it, he'd had it, right? And a lot of it. And his surgeon was right next to me. And I'm looking at the patient, and I'm looking at the surgeon, and then I'm looking at the patient, and I'm like, oh my God, these guys look exactly alike. And Dr. Phil is like, now, do you think that you've had too much of the plastic surgery? Are you doing okay? Kind of like that. He's like, oh, I'm going to have a party for my 50th operation. It's going to be great. And, my doctor so-and-so is going to be there. I won't say his name. You guys can all refer to the episode. It's back in the day. Like back in the day. I've been around a long time, people. And I'm sitting there just like, you can only imagine, right? My thing is the natural lift, the natural nose, the natural this, natural. You're going to look normal. You're going to look great. It's a better version of you. That's my whole shtick.
Even if it takes 15 surgeries to get there.
So anyway, I'm sitting there like listening, trying to control myself. And I think Phil noticed smoke coming out of my ears. Just, he goes, and I see him looking at me, and I know him and Jay McGraw, because like when Orden got onto the doctors, I was the one who called Jay McGraw. I was like, I can't do your show, but this is the guy who can. And I said, Dr. Orden's amazing. And so I'd known them ever since, because Dr. Orden went on to be a very famous and successful host of the doctors. Anyway, Phil turns to me and goes, well, we have in our audience today a plastic surgeon known for his natural results, Dr. J. Calvert. Dr. J, what do you think about this? And I just went on. You talk about this being a rant-free zone. This was like a rant-away zone. And I just went nuts. And I was just like, oh my God, this is like the wrong message. I went crazy. I go, this is not what plastic surgery is about. It's not powerful. It's not what we're trying to do for people. Like this concept of having a party for your 50th operation, like you can die from these operations. There's surgery involved. It's a real operation. Like, no, like just going crazy. And Phil like kind of hid behind the sofa on a stage and was just like, I knew this was going to happen. And they played about 2% of what I said and never invited me back. That was the bottom line.
There it was. So yes, short answer, plastic surgery can be addictive.
But in most cases, it's not.
But if you have one, you'll probably have more.
If it's successful.
And
most of the time, it is.
Brings me to my next question. I know it's your turn, but this one feeds right into it. And it's not really a question. It's more of a statement. I just had plastic surgery. I don't like my results. I've been botched. I get that
all the time.
all the time. And I don't know what it is about that term that just irritates me. And so everyone knows botched, right? Because it's the show that's very successful.
show.
It's a TV show. It's patients that have had plastic surgery and it's gone wrong. And they go onto this show and the doctors, fix it, make it better or not if they can't do anything. So the terminology botched has sort of permeated our culture. But just because you don't like your results does not mean you've been botched. Maybe you weren't the right candidate for that surgery. Or maybe that surgery wasn't the right surgery for you. Or maybe you had different expectations than what was actually delivered. Or maybe it was an okay surgery, but not great. So there are lots of things that maybe you don't like about the result, but that by no way, shape, or form means that you've been botched, because botched carries a really negative connotation, which means something horrible happened during your surgery, and maybe you just didn't get the results that you thought you were going to get.
Yeah, I think that term is, because it's been bantered about so much, it's been watered down. So I don't think it has the same effect anymore. I think they say botched when they don't like the result.
I guess. I hear it, though, and I just cringe because I'm like,
I don't know.
you're bashing your plastic surgeon, and they did a fine job. You thought you were going to get something different, or you don't like your result. But, he did a fine job,
That happens a lot. So the thing that got me into the nose game was revision rhinoplasty. And I see a lot of people who are unhappy with their rhinoplasty results, but they really don't have a bad rhinoplasty.
Right.
It isn't bad.
They just don't like it.
They don't like it.
Yeah.
Yeah. And so that happens a lot. And I can, and that I'm sure it happens with me. I'm sure my patients are in other people's offices. I know they are, because I know of patients that went to friends of mine and, they had a fine operation, but they really didn't like the result.
Right.
And I had a bad review on Yelp one time that was it hit home so hard for me. This kid that I did his rhinoplasty and it went swimmingly. It was perfect. Everything that we talked about, it was all there. And then this Yelp review comes up and it's clearly from him. He puts his name on it, which most people don't. So he puts his name on it and says, I went to Dr. Calvert and I wanted this, that, and the other thing, but he didn't listen to anything I say. And this is what I got. And I'm so unhappy with it. And I wish I would have done this or said that, whatever. And I read the review and I was just like, oh my God, all I did was listen to this kid's parents. And I remember he didn't say a word, not a word in the consultation.
Some miscommunication.
And it was all the parents that drove the consultation. And they said this is what it was. And I literally answered back. I was like, oh my God, you have to come back in. I have to help you. I totally missed this. This is my fault. I didn't listen to you, because he was a young kid and his parents were just
talking
they just
for him.
barreled through. And it changed my entire approach to teen rhinoplasty. Changed everything that I do. I tell the parent, the parents come in, blah, 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 blah. I'm like, that's nice. Why don't you get out of here and let me talk to your kid and I'll tell you whether or not this is on. Because I want to hear from the patient, even if they're under 18.
Well, that's what the pediatricians do. They kick the parents out at
That's
age 14. Bye.
Boom. Get out of here, because I don't want you to direct traffic on this. This is their face. If they can't point to things and tell me what they're looking for, we're not doing a rhinoplasty. And it radically, this was in 2006, it radically altered my entire approach to teen rhinoplasty, which has been such a joy in my practice. But I'll tell you, that's the thing. You have to be paying attention to the details.
And there it is. All right.
And there it is. You want one?
Yes.
All right.
My turn. What you got for me?
I've got several.
Okay.
Hang on one sec. Do you want a surgical question or do you want a Medispa question?
Surgical.
Oh man. Is there a hurricane shelter or tornado shelter nearby?
Uh-oh. Okay.
I'm ready to ask this one. Maybe I should get under the table and aren't you supposed to cover your head?
Something like that.
I know it's been a bad week for you. So this may be a sore point. And not because of what you've done. It's because of what somebody else did. Are cosmetic surgeons the same as plastic surgeons?
Ooh. Ladies and gentlemen, I was on call last week for a local hospital, and I got a few consults when I was on call from surgeons in the community that were not plastic surgeons.
They are not plastic surgeons.
Are not plastic
This
surgeons.
is not a plastic surgeon.
Okay, so let's distinguish this. A cosmetic surgeon is a surgeon that has done some kind of surgery residency. It can
Not
be
necessarily. Not necessarily.
No, in the United States, it has to be either like a oculoplastic or some kind of general surgery or ENT or I don't know, anything where you cut things, or you can do some kind of surgery. You can't come into it from a medical residency.
Oh, I thought you could do like internal medicine and then get boarded in cosmetic surgery.
No, usually you have to have some kind of surgical background.
Okay.
So it's
all right. I'll give you that.
An oculoplastic, a general surgeon, an ENT, an OB-GYN, someone that did a residency that has some kind of surgical experience. And then they decide they want to get into the world of plastic surgery, but for whatever reason, they don't want to do a full 2, 3, 5, 6-year plastic surgery residency. So they just cut straight to the cosmetic part and do a 1-year cosmetic surgery fellowship. And usually these are with other cosmetic surgeons, not plastic surgeons. Plastic surgeons do either a 6, 7, 8-year plastic surgery residency, or they do general surgery, ENT, and then another 3 years of a plastic surgery residency. So the training is much different. The training of plastic surgery is very comprehensive. So we do reconstructive, we do burns, we do pediatrics, we do the whole gamut, including aesthetics,
a lot of aesthetics,
cosmetic surgery, and that background and that bag of tricks that we come with makes us better trained. And I try to be like PC about this and say that we're all No,
I'm not going to be.
We are way better trained. We have way better skills. We have way more knowledge of what we do. Now, maybe someone who's done cosmetic surgery for 30 years may have something, but they just train differently. They don't go to the same conferences we do. They don't have the same caliber of competition amongst their peers. And what I saw last week from a cosmetic surgeon in our community made me just cringe, because as a woman, here we're going to use the word botched. This is a good use.
This is where the word botched comes in.
She has a permanent cosmetic deformity after this surgery and that I am now taking care of as a plastic surgeon, because I was on call for plastic surgery when she came in with a plastic surgery problem.
Right. They don't have cosmetic surgeon on call.
The cosmetic surgeon on call, because that's not a thing.
Well, it's not. Let's be clear. Let's split hairs here, because it's real. It's not an American Board of Medical Specialties approved specialty. The American Board of Cosmetic Surgery is a private corporation designed to board people that meet the requirements of whatever they are, that they've done some fellowship in cosmetic surgery after having, evidently you said it's some sort of surgical background, but I don't think that they need the surgical background. That may be true. I don't know that. So I want to be, totally clear that isn't known to me, because I know cosmetic surgeons, or maybe they're just people that are doing cosmetic surgery, that the guy across the hall from us that got taken out of our building by a SWAT team was not a trained surgeon. I think he was a family practice guy that decided to do tummy tucks in an exam room. Which
you can do. There is no law or rule against that.
Nope.
If you have done 1 year of residency, you have a freestanding medical license in the state of California, and your license says physician and surgeon.
That's right.
So you can open a practice and cut on people. You can't get hospital privileges to do those procedures, but if you have a surgery center, or you do them under local, or you have a garage, you could theoretically do surgical procedures. So please go back to How to Become a Plastic Surgeon podcast.
Absolutely.
And
how to choose your plastic surgeon.
Choose your plastic surgeon. What does it mean to be board certified in plastic surgery? And go to a plastic surgeon. I'm tired of mincing words. I tried to be really polite and PC. I know cosmetic surgeons are great. Go to a plastic surgeon.
No, it's facts. That's all it is. We're just talking about facts. It's not about whether it's right, wrong, up or down. We are not here for any kind of like judgment. We're just saying that if you want to know that you have an actual plastic surgeon as defined by the American Board of Plastic Surgery for, breast, body, face, nose, whatever, then American Board of Plastic Surgery kind of gets you in that boat.
Right.
I think
Stack the cards in your favor.
The American Board of Facial Plastic Surgery gets you into the boat of somebody that knows how to do rhinoplasty, facelifts, fat grafting the face, brow lifts,
Right.
The ASOPers, which is the Board for Oculoplastic Surgeons. These guys are really good with eyelid surgery. They can handle everything around the orbit. There are certain things, and we have gone out of our way to lay those kind of facts down on this podcast, not for any other reason, just to let people know this is the information you need.
Right.
It's not better, worse, up, down, whatever. In the end, I say look at the before and after photos, make sure they're legit, and then go ahead if you think that that's the surgeon for you. Always best to get a referral. Always best to confirm that the surgeon is board certified by one of those boards that we've mentioned. And then make sure that you have a good plan with that surgeon that you have decided upon and that you feel comfortable. It has to be a team effort to get a great result with plastic surgery.
I agree. All right, so let's see.
I knew you'd like that question.
I like that one. That one.
I knew it.
That one got my blood boiling a little bit. All right. I think we have to sort of tailor this and cut it short a little bit. So I'm going to give you options. I'm going to give you two options.
Okay.
Here. Do you want a surgical question or do you want a dirty post-op question?
I kind of want them both. Is that okay? I mean, I kind of want to hear them.
All right. I'll give you the surgical one first, and then we'll end this with the dirty ones.
Okay. Do it.
My doctor said I needed a breast lift, but I don't want scars. Can't I just put an implant in? That's what I came for.
As in many things in plastic surgery, it depends. So that depends on...
Do you like having pretty breasts or not?
Yeah, well... Yes. I mean, it depends how much breast ptosis there is, which we've talked about on the Mastopexy podcast. Is there too much drooping of the breast? Can you fill it up? There have been many patients that have come in with like a little bit of sagging of the breast and deflation after pregnancy where they've gotten postpartum involution of the breast. And I've said, how do you feel about having like a little bit bigger breast?
Saggy breast.
Just a little bit more. And they go, well, I think that'd be okay. And then it's like, all right, well then if we can do that, now I can just fill it up with an implant and you're good to go. So that's doable in some cases. There are other cases where it's just too far gone and you're going to need scars and you have to have it lifted. And your plastic surgeon should be very clear about that and tell you that.
Right. So if they are hardcore suggesting you need a lift, you probably need a lift. I had a patient recently that came in and the nipples were pointing down to the floor and she adamantly refused. She did not want to lift. Are you going to top me up here, doctor?
Let me help you out here.
Thanks. She did not want to lift. She did not want the scars on the breast. Can't you just put an implant in there? And I think she already had implants in place. So I knew what it would look like if I just replaced the implants. And I was like, no. She didn't want to pay for it. She didn't want to do it. She didn't want to have the scars. She's like, I just want the implants, put in and taken out. I was like, I can't because it's gonna look awful, and I can't. Maybe there's another surgeon that will do that for you, and you should go and see them. But doing a suboptimal surgery that's gonna have horrible aesthetic results, horrible. No, sorry.
Yeah, we're not signing up to be your surgeon for results that are not going to make us look good.
No.
We want the results to reflect our aesthetic
yeah.
abilities, concepts, our thinking. You know, we want to like hit amazing home runs for everybody.
Yeah. I mean, there is, yes, this is absolutely about the patient. We want the patients to be happy. But at the same time, this is our job. And I need to walk out of that OR feeling good about what I did in that OR. And knowing that 100%. I did a really subpar operation for a person.
No.
Because it is a little bit about me too.
Well, you know when that happens is when you listen to the patient's idea of how to do surgery. And then it's like,
So many, and not to say I haven't done that. I clearly have done that.
we all have.
But I don't feel good afterwards.
No,
I'm
it's like,
yeah, that's it.
and they're like, if you just do this, I'll be happy. And then they're not.
So here's the thing, as a patient, don't make up surgeries. Because sometimes we will take your advice and just do them because we want to make you happy.
We're trying to make you happy.
Trying to make you
We're
happy.
Like, yeah, I guess you could do that.
Yes, but like sometimes surgeries don't exist for like a very good reason. So don't make up surgeries and don't convince your plastic surgeon to do surgeries that don't exist because there's a reason they don't exist.
Like the reverse abdominoplasty.
Save it for the next one.
Oh no. I can't even. I won't even.
All right. You have one more for me, or should I go to my dirty ones now?
Go to your dirty ones.
My dirty ones.
I'm
Okay.
ready.
I have
ready for the dirty question.
Dirty ones. Okay. I have two. This was a real one, and it made my day. 2 weeks, maybe 2.5 weeks, after a huge 360 around the body, tummy tuck, lift, the whole deal. She's doing great, doing swimming. Doctor, I know I can't do anything too strenuous. And I know you said I probably shouldn't have sex right now. Can I have sex with myself, though? Like, because I really need it. Said my 67-year-old patient who's 2 weeks from a huge surgery. Can I have sex with myself?
2 weeks after a huge operation.
Still has drains.
I think that's also going to fall. It's going to fall under the category of it depends.
It depends.
Because we don't know what sex with yourself actually means. So I don't know. I don't know if you can. Maybe you can. Maybe she still has drains?
Still has drains.
Still has drains.
Still has drains. I mean, it's been like 2.5 weeks. It's time.
Jeez.
And I said, sure, go for it.
Yeah, I mean, didn't you want more detail? Because what if like that's like
No.
you're just we're gonna like hope for the best?
I did not
Because
want...
you don't know like what that means.
There's only so many things you can do with yourself.
Well, some of it can be pretty rough. That's what I'm saying. I would probably want to like dig in a little. You know. Yeah, I mean, I think you need to know. Look, the bottom line, you don't want to break incisions open. Like, there's a lot of things you don't want to happen. She's still got drains. She's still in a pretty acute phase of healing, and now she wants to go and like do something strenuous and crazy. It could be a problem. I mean, it couldn't like sex with herself could mean like renting her friend's dungeon and doing,
True.
swings and whips and like you don't know what people do.
True. Maybe I should have asked.
You gotta get some more detail. I think. Look, I don't judge, and I think everybody's got their thing. It's you just have to be like open-minded and careful. And we don't sit there and try to say, oh, you shouldn't do that because it's bad or anything. Well, you shouldn't do that because it's bad for your surgery.
For your surgery, right?
I don't care what you do. I really don't. I'm not going to sit here and say you should do it this way. That's not my job. My job is to make sure you get a great result. So,
which brings me to my second question, which I got literally today. So, if I do have sex, how should I do it? What positions should I do or should I not do? So now I actually am asking you, doctor, how should I do it? This was the best conversation I had all day, by the way.
Well,
because we really broke it down.
I got it. I mean, look, I get it because you don't want to hurt your operation.
And there is a way that you can do it without hurting your operation.
So what I tell people in a very discreet and sort of palatable manner without having to get, graphic and sort of rude about the whole thing. I just say, look, be careful, be smart, find ways to do things that are gentle, that you're going, like, I get it. People like having sex. You should. It's fun. That's kind of part of the deal.
Right.
You have a, husband, a wife, a partner, whatever you have, it doesn't matter.
New boobs.
Yeah, and now you got some stuff going on. It's all good, right? So then it's like, well, just use your common sense, be gentle, don't put any, like I said, don't stretch anything.
Right.
Don't push the envelope. This is not the time to create, new athletic maneuvers, is the term I use. And just be smart about it. And if it hurts, don't do it. So that's sort of the way that I look at it, because I think you can have sex. I mean, there the operation's very focal in most cases. In a 360 like butt lift and tummy tuck and a whole body lift like that, that's a little different. Then you kind of really got to be careful.
Got to be careful. Right?
You do. I mean, because I will tell you the story. Back in 2005, right when I got into practice after leaving UC Irvine, getting up to Beverly Hills, this guy who's probably 55, 6, 7 at the time brought in his, 23-year-old girlfriend for a breast augmentation. I was like, great, we got this. And, so we do the breast augmentation. And that night that I did the breast augmentation, I get a phone call. The right breast is blowing up like a balloon. I was like, what do you mean it's blowing up like a balloon? Like it was a dry operation. I was like, what happened? What's going on? He's like, well, we were having sex and I was trying to, and literally was trying to like road test the surgery the night of the operation. I was like, dude. I was like, really? He's like, well, I just figured they're in and it's done. And it's like,
no,
like that is so not how this works.
So that was a little too soon.
I was like, that is so not how this works. Are you kidding me?
Yeah.
Really?
You need some time on that one. But at least he owned up to it.
Yeah, well, he did. He was saying it like there was nothing wrong with it. So, like, he clearly thought it was completely okay. Like, I got the breasts in, now I'm ready to use them, and we're good to go.
Yeah.
I was like,
no.
Did you read the pre-op? No,
yeah.
You didn't. Never mind.
These are things.
Come on in, let's drain the hematoma, and then we're going to fix it.
And then you're good with it. You got to let yourself heal internally. I kind of say the same thing. Think of it like strenuous activity, exercise. You got to give these incisions time to heal. If you can do something that's not going to be strenuous and it's not going to put friction or a lot of tension on these incisions, once you get to 2-3 weeks, probably fine. Even then my patient really wanted me to get into specific positions. So I was like, okay, well, here we go. Okay, so pillow princess, missionary, probably fine. Don't get like nothing too hard. Like just, take it easy. And you try and say use common sense, but sometimes people don't have common sense. So you have to be really specific. And she's like, well, is that really the only position I can do? I'm like, okay, if you're on top, you're bouncing around too much.
Like, Jesus,
it's too much.
Really?
You can't be like on all fours. That's too much pressure on your incisions. Like I had to really
walk her through this thing.
Down for her. And I was like, just lie on your back. Just take it. Like, just.
Oh, that's classic. Really?
These are things that people
does it seem hard to
know.
understand? I mean, is that hard? No, it's not. It's not hard.
Well, hopefully. Somewhat hard.
I'm,
See, that's what happens when you give me champagne.
I think, for a 200th episode, I think we've hit the mark. We've done it. I have a question for you now.
Okay, yes.
Going forward, what do you want out of this podcast? What do you want? What do you, as a host, want out of this podcast? What do you want to do for our patients? Like, we've covered lots of topics. We're going to keep covering, and we're going to revisit topics because this surgical specialty of ours changes on a 6-month basis.
Keeps evolving. I think I would like to bring in more patients, more patient experiences, which we say all the time. And the only hiccup for that is just the organization of it. You and I are very busy and like trying to organize our patient schedules, and our schedules tends to be a little bit difficult. But I do think people really like those patient experiences. And so I would like to see us doing that a little bit more.
Yeah, I think that's a good future kind of goal is to get more patient sort of stories on our podcast. What about innovations? Any, like the inventors? Do we need more? We have a lot of people asking to be on this podcast now, which I think is interesting. I get a lot of inquiries from PR people. They're like, hey, your podcast is one of the top 10 plastic surgery podcasts in the country, which, where did they get that stat? Like, I don't know where that came from.
I don't either.
And we'd love to have our client, so-and-so on your podcast. We'd love, him to come and talk about this or that. And, he's the inventor of this or blah, blah, blah. Like, okay, come on in. But I think the patients are key. I think there's, just for everybody who's listening, like, we're sponsored by nobody. We pay for this podcast ourselves. So we don't have anybody whispering in our ear like, just say so-and-so 10 times during the podcast. Just tell them about this treatment. No. We are like, we're free of encumbrances that way, from that. So I think that's important. But I think going forward, I want more like down to earth, raw descriptions of what it is that happens for people, because I think plastic surgery has become more, it's a safer process, and it's a more effective process, and the reliability of me with a rhinoplasty is light years ahead of when I started in 2001.
I'm sure.
It's light years. I can't even put it into a comparison of it. It's so different. When we were doing rhinoplasties in 2001, and yes, I was very new in practice, but even like what we teach the fellows and the reliability of plastic surgery is so much different. It is, you can go and get a great rhinoplasty. You can get a great breast augmentation. You can get great operations because the teaching and the technology has evolved so much. It's really shocking. It's so different. And it's great for the patients. Like, they can go in and be like, I'm getting a facelift and they look amazing. I'm getting a nose job. Great. It's awesome. Here's my breast augmentation. Amazing. And that's basically what happens if you go to a board certified plastic surgeon. I'm going to qualify that statement, because I think the training's just, it's light years ahead.
Yep. And that's what we try and talk about on this podcast. So I think that is where we will continue to go.
Well, let's do that. So here's to another 200 episodes, if we can do that, which would be awesome. Cheers.
Cheers to that.
And this is the Beverly Hills Plastic Surgery Podcast, coming to you from the 90210.